So much, Anthony. I appreciate that. So today I'm going to talk about the effects of subconcussive impacts on varsity hockey players. I'm under the supervision of Dr. Jim Dickey at Western University, as well as Dr. Laura Graham out of the School of Physical Therapy, also at Western University. Two great people. Definitely loving that. So I'm going to give you the definition of sports-related concussion. So this is from the last concussion consensus statement. We are for a new one, but obviously with COVID, it's going to be a little bit delayed. So sport-related concussion is a traumatic brain injury induced by biomechanical forces, and there's several common features, and they're listed below, and I'll give you kind of the ad lib of them. It's a direct blow to the head, face, body, neck, or elsewhere in the body, with rapid onset of impair of neurological function. There's a neuropathological change related to function rather than structure. That's why we don't use CTs or kind of head scans, as there's no structural damage, rather it's related to function. And it may or may not involve loss of consciousness, and the resolution of symptoms is often sequential. So we have those return to play protocols or return to learn, but sometimes they'll be prolonged, or we'll get into post-concussion syndrome about if it's 3 months from resolution. So we have some subjective concussion assessments. So the SCAT-5, which I'm sure many of you are familiar with, which are made up of the Maddox questions and the standardized assessment of concussion, the SAC, the post-concussion symptom scale, the River-Mead, the brain injury vision severity symptom, the GAD-7, and the head impact inventory. And these are great assessments. They really give us an idea of what the player's feeling. But what's difficult with these is they go through the player. And I love players. They want to play, but sometimes they can what's called sandbag these scores. It's published literature calls it sandbagging, but they want to play, and I don't fault them for that. But again, when we're trying to recover from a brain injury, we want something a little more objective where we're not taking that extra context of I don't want to get out of the game. This is the championship. This is the playoffs. Like I don't want out of this game. So we have some objective concussion assessments, which include the impact, computer-based test, the King-Devic, where we're using saccadic eye movement, which I'll describe later, and reading numbers, saccades, smooth pursuit eye movement, so through eye tracking, EEG, the vestibular oculomotor screen, and the balance error scoring system. So all of these are objective markers. Players are performing a task, and we give them a score, and they're put on a percentile. And a diagnosis is not made from this. We'll need a doctor or a physiotherapist to kind of look at these scores and make that diagnosis of concussion, but they give us something where the player can't lie or kind of fabricate these results. So what's the difference between a concussion and a subconcussion? Well, a subconcussion is an impact to the head or body which does not result in concussion symptoms. So out of Anthony and mine's lab, we have Dr. Jeff Brooks here, did a study on the Canadian university football and found there was an average of 24 impacts per game to players. And this was a huge range where quarterbacks were at 2 and linemen were at hundreds. The effects of subconcussive impacts in the brain are not well understood, and they manifest slowly. So rather than where we think of a concussion and a totally different person is on the field, where these things add up slow, it's hard for friends, families, team doctors, family doctors to notice these changes. So they accumulate over time without clinical presentation and may not even be seen by physiological markers such as EEG or MRI, or even diffuse intentional imaging, where we're looking at that brain structure, because they occur so slowly that we need successive measurements of these things where it's just not feasible. So we'll get a little bit more in the methods of the study. So we looked at impact tracking. So we had the GFT impact trackers here, shown next to a quarter, very small in size. And they're a device that measures head movement that are caused by impacts to the head or body. And they record the number of impacts and biomechanical data related to them. They're not used for the diagnosis of concussion, but there are numerous devices in the market at this point that are either embedded within the helmet or this one's external. So as you can see, when we affixed it to the rear crown of the helmet, so it was in every player's helmet. And we chose to look at number of impacts. As many of you are aware, hockey helmets fall off. So if we were looking at pure data and the helmet shifts, then we're not going to get true biomechanical data. And we figured that this would be a little bit more applicable, whereas if you don't have these impact trackers, you could have a coach counting impacts for a player. So we looked at experimental protocol. Player impacts were measured over a 24-game season, and we also looked at EEG. So we used 2 baseline measures and an oddball paradigm, which I'll describe later, as well as saccades, pro and anti-saccades. So for the oddball paradigm, players were presented different shapes. So this was the common shape, a large blue circle, and the uncommon shape was a small blue circle, which players would have to react to, or a checkerboard, which is a distractor. So from this, we'd get a brainwave called the P300 ERP, event-related potentials that's related to the event of reacting to the circle. So we have 2 subwaves, a P3A and a P3B. Not getting into details of this, but from this, we can look at attention and decision making. And those are important things for return to learn and return to play. So we looked at this as one of our markers, and EEG is well validated. And then we also looked at saccades. So saccades are jumping eye movements as shown in this GIF at the bottom here. And we recorded them at high-speed cameras, 240 frames per second. And we measured the latency of first pupil movement and directional errors. So we were accurate to 4 milliseconds, and we just used GoPros. And we thought that this was great because it's applicable and many teams can afford these. So a pro saccade would look like this. So if you were the player, there'd be a fixation point in the middle of the screen. A green fixation point would denote a pro saccade. A stimulus would be presented on the left or right. The player would shift their focus to that stimulus and back to the center. However, for an anti-saccade, which is a measure of executive function, that same stimulus would be presented, but the player would have to inhibit that initial response and look to the mere opposite of that target and then back to the center. So that is a measure of executive function, and we can look more at latency time and directional errors. So you looked at 22 players, 9 defensemen, 13 forwards, and no goalies. As usual, coach wouldn't let me touch the goalies. We tested at 4 time points. So we had preseason, pre-break, post-break, and postseason. So as many other university hockey teams may be aware of, they would play half the season, take a break for exams and Christmas, and then complete the season. So what we hoped to see was a decline in function, some resolution in this decline, perhaps even an improvement during this month-long break, and then a continued decline in function. However, as our results you'll see in a minute, did not find that. So what we found is players accumulated 267 impacts over a 24-game season, and this ranged from 507 to 34 impacts. And we also got some other data, including impact location. But again, with the helmets not being affixed securely, we didn't feel comfortable looking at specific biomechanical data, rather just pure number of impacts. So these charts below denote saccade latency times. So we have our 4 time points and then displayed throughout. And as you can see, there's no clear rhyme or reason to what's changing with these players. Green lines denote players below the median number of impacts, what we denote as low impact players, and red were high impact players above the medium impacts. So what we were thinking from this data is that the players just did not occur enough impacts to have meaningful change. They didn't get that threshold where we see change in saccadic function, which is a very basic human function. So we have to have big change for our body to have change in that realm. So that makes sense, but a little disappointing at the end of the day. But it's good to know that these players were doing well. However, in our P3A measurements and with our EEGs, so this is related to attention, shifting attention. You know, you're in class and you're going from looking, writing a note to back on the screen, or you're in the game and you're looking at the puck and then you're coming up and looking at the defenders and trying to plan your route out. So it's important for return to learn and return to play. And as we see, players are pretty level throughout the season, but both low impact and high impact players from mid-season to postseason. So during that second half of the season after the break, they all seem to have an incline in this P3 latency. So what we think is that during this point, all players passed the threshold for changes in the neurophysiological function of the brain. We don't know what that exact number is, but we know that it's somewhere on the higher end, again, above that 267 is what we're thinking. So again, with more detailed and longer analysis, we can get more into that, but it's important to note, and we want to do some higher level statistics to find out what that specific number is. Executive function, so for our results, executive function as measured by anti-saccade latency does not appear to change as a result of head impact exposure in male varsity hockey players. However, these trends are, there's trends towards increased P3A latencies as the season progresses. So what we're thinking is related to attentional resources. So it may be that there's a change in function and players are having to spend more resources neurologically to be able to get the same neural output. So there's the function and the physiology has been impaired. So what do we think about future directions and where do we plan to take this? So we want to take this to all levels of play. And what we thought is what would make the most sense is implementing a hit count. So if we think of Little League Baseball and there's a pitch count, you know, Timmy gets 100 pitches a week. Well, maybe player X or player A, maybe he or she gets so many head impacts per week. And do we want to spend that 100 impacts in the practice, or do we want to save them for games so we can keep players below this threshold where we're seeing neurophysiological change? Perhaps implementing more bye weeks so that players get a chance to rest from that accumulated impacts, or the halting of as many off-season leagues. We know a lot of players go from League 1 to League 2 to League 3. They're playing all year round and never getting that break from accumulating more and more impacts. So again, focusing some time off, especially for younger players where they have that ability or they're not going to hurt their chances that way. So I'd like to give a special thanks to Dr. James P. Dickey, Laura Graham, Jeff Brooks, and Coach Clark Singer for allowing me to do this project. And if anyone has any questions, you can email me at the email here or follow me on Instagram at phdill to watch my journey through the combined physical therapy PhD program here at Western. Thank you for your time. And if you guys have any questions, I greatly appreciate that.
Any questions for Dylan? Dylan, great job, my friend.
Thank you.
Everybody,
I appreciate
it. Everybody good on questions? Ladies, gentlemen? Okay. I'm just pulling up the itinerary, and it looks like Matthew Kelly is next. Current concepts in pathomechanics of hip pathology and ice hockey players. Matthew, you are up, my friend.
Thank you. Let me just share here. Okay, you guys can see that? Yeah?
Yes.
Okay. Yes. Okay, perfect. Thanks. Yeah, so the title of my presentation is Current Concepts in the Pathomechanics of Hip Pathology in Hockey Players. So this presentation actually came from a lit review that I did from my original thesis that I was supposed to be wrapping up this year. But with COVID, it didn't really come to fruition. So I thought I'd still share some of the stuff that I found interesting during that lit review. So hockey is often known as the fastest game on earth, and it really keeps getting faster. So as you can see on the graph on the right here, these are the times from the winners of the fastest skating competition at the All-Star game over the past 20 years. So you can see that there's a continuous decline in time, which would suggest that players are getting faster. And we're seeing guys like McDavid here, McKinnon, Barzal, who are kind of leading the way in this trend and making the game really exciting for fans to watch. But at the same time, we're also seeing a rise in non-contact hip problems. So we're seeing a lot of guys having surgeries, guys whose careers are being cut short because of hip problems. And so, it kind of makes you think, are these two related? Maybe. I think there's probably other factors that go into this rise in hip problems, particularly earlier specialization within the sport. So we're seeing a lot of kids who are specializing early, and also just our knowledge of the hip in general with the evolution of hip arthroscopy over the past 20, 30 years, and our knowledge of diagnosing and treating the hip from that could also be a big factor in this. Some of the more common known pathologies, hip pathologies in hockey players include cam deformities or FAI, or femoroacetabular impingement, hip labrum tears, adductor strains, core muscle injuries. Some of the less commonly talked about pathologies would be like ligamentum teres, and hip microinstability. And so I'm going to kind of focus a little more on these three today, just kind of how they're related and what effect they might have on a hockey player's hip. So before we go any further, I just want to be clear that like hip pathology doesn't necessarily equal pain. So we know that from lots of studies, not in hockey players, but also there are studies in hockey players that show that a lot of them have hip morphology, hip pathology, but don't necessarily have any symptoms related. But I don't think that we can completely ignore this. I think this is something that could have an effect on their function and performance. And that's kind of what I'm going to be talking about today. So just a quick review of the anatomy of the anterior hip. So I like to look at it in layers. So first, we'd have the bony layer where you have your pelvis, your acetabulum, hip socket, femoral head, neck, and shaft. Layer 2 would be your static stabilizers, where you have your labrum, your ligaments and capsule. And layer 3 would be more your active stabilizers, or your muscles, hip flexors, adductors, groin, quads, hamstrings, glutes, etc. So looking at the pathology of the bony layer, the big one here are these cam deformities, which are essentially just these bony growths on the femoral neck that you can see here. I think early on, the thought was that the flexion, adduction, internal rotation of skating is what was causing this, where we would get contact between the femoral neck and the acetabular rim. I think we're starting to kind of lean more towards that they're related to the cumulative skating, especially starting at early ages. So you can see in this study here by Mark Philippon in 2013, so they measured the alpha angle, which is essentially the size of this bony growth in peewee and midget hockey players. And they found that there was a greater number of peewee players who had smaller alpha angles compared to the midget players who had these larger alpha angles, which would suggest that there's probably some correlation between the size of the alpha angle and just general development, but also likely some relationship with the accumulation of skating over the years of playing high level hockey from a young age. The other thing with these cam deformities is that they're also highly correlated with labrum tears. So we often see both kind of hand in hand when we're treating one or the other. And so these labrum pathologies, I think, might also be related to skating mechanics. So if you look at the skating stride, we see a lot of hip abduction and external rotation, especially at the end of the push-off. And you can see here in this study by Olivier and colleagues, they looked at the strain on the anterior labrum by inducing an external rotation torque at different degrees of hip abduction. So you can see that between 20 and 40 degrees of hip abduction is where they found the greatest strain on the labrum. And this is the expected range of hip abduction in a skating stride that you would normally see. And so the repetitive motion of skating and the constant strain on the labrum can lead to microtrauma of the tissue and eventually possibly tearing of the labrum. And when the labrum is torn, it loses its function as a suction seal. So it almost creates like a suction cup on the femoral head. But when it tears, it loses that function, and we get this wiggling of the femoral head in the hip socket. And that's this concept of hip microinstability. I kind of like to think of this almost as like a loose tooth that's not really ready to fall out. So the tooth is going to wiggle, but you can pull on it and it's not going to fall out. So the same thing with the hip. You're not going to dislocate your hip because you have a torn labrum, but you will get more movement in the socket with a torn labrum. And so looking at some of the pathology of the active stabilizers, hockey players are known to have a lot of soft tissue problems around the hip, groin, hip flexor, abdominal wall. I think that there are times where we might be overdiagnosing this, and that we're kind of just seeing the tip of the iceberg, where we're seeing these soft tissue, what are seemingly soft tissue injuries, but in reality, they're probably more issues that are under the surface and deeper inside the hip. So if we look again at the anatomy, you can see that the hip flexor runs right over top of the anterior labrum, which is typically where we would see a labrum tear in a hockey player. And so when we get this labrum irritation or labrum tear, and we get this wiggling of the joint, the muscles are going to try to protect that, and they're going to guard. So they're going to increase tone. We're going to feel this kind of like tightness in the hip. And then we kind of fall into this cycle of hip tightness and hip discomfort, where we get the static stabilizers pathology or irritation of the labrum. We get protective guarding from the active stabilizers, or the muscles that are just trying to help out and trying to protect the joint. We get this perception of hip tightness and discomfort. And what do we do with that? Well, we stretch and mobilize. The problem is when we stretch the muscles, we decrease the tone, and then we just increase the wiggle of the joint again. So we kind of fall into this cycle of stretching, increased wiggle and possibly irritation, increased guarding, and we kind of end up being a dog chasing its tail. We're kind of just chasing symptoms, and we're never really getting to the root of the problem. And so with all of this information from that lit review, I've kind of changed my approach in the clinic. So for those of you who don't know, Mike Reynolds is a physical therapist, well known in the baseball community. One of the things that he always says is poor static stability requires pristine active stability. So when you're talking about a baseball pitcher's shoulder, they often have loose capsules, they often have labrum tears, so they don't have great static stability of the shoulder. So they focus on rotator cuff strength and coordination to make up for it. And I think we can also use that statement around the hip. The hip kind of has a similar configuration of what you might call a rotator cuff. And so without the stability from the labrum and potentially from the capsule, I think if we train the active stabilizers, if we strengthen those and increase coordination to increase stability of the hip, we can reduce the threat of this micro instability, which would lead to less guarding and less perceived hip tightness and discomfort. So in summary, players are faster than ever before, and we are concurrently seeing a rise in hip issues in hockey players as well, which is likely multifactorial, with the speed of the game possibly being a factor. The common hip pathologies in asymptomatic players, although they're not necessarily problematic, they might still have an impact on performance and health. And I think that by training the hip cuff, we can reduce the effects of microinstability in the hockey player's hip and hopefully help them perform better and feel better. And here references. And yeah, I'd be happy to answer any questions.
Yeah, I have a question, Matthew.
Sure.
So do you think the skating motion, so basically you're referring to just the skating motion itself creates these hip injuries, is that correct?
Not necessarily the skating motion itself. I think it might play a part in it.
But
Which
what
injuries
I'm thinking,
are you talking about?
Yeah, I'm thinking maybe, is it the skating motion, but then they get checked or they get bumped or something like that? That could lead to the hip injury, and maybe it's not the skating motion itself, because I'm thinking more along the lines of Bo Jackson, you know, the American football player who basically was running and got bumped. It wasn't anything serious, but it just caused enough change in his running stride or gait that led to a fracture of that femoral neck, and he had basically a vascular necrosis. And so I'm sort of thinking the same thing with hockey players. I don't know if it's just the, you know, if the skating motion itself that might lead to the hip problems, or is it just maybe that they're skating and then they take a bump and then that causes that extra force to create some of the issues?
Yeah, I mean, it's definitely possible. That's not something that I had really considered before. Yeah, I think it's a good thought. I wouldn't disagree with what you're saying. Yeah, I think that's an interesting thought. It's definitely possible.
Yeah. And have you looked at goaltenders at all as well? I know you didn't say anything about that, but I was at a USA hockey conference a couple of years ago, and the Dallas Stars hockey coach was there, or the goalie coach was there, and he was talking about the hip injuries that young goaltenders have. And I was shocked that he was talking about how many kids have bad hips because of the butterfly and all that kind of stuff. So that was interesting, but you know.
Yeah, I mean, I didn't really get into goalies, mainly because the project I'm working on was, but yeah, I think it's kind of across the board. There's these high rates of hip injuries in youth athletes and in professional hockey players as well.
Well, thank you.
Thanks.
Matt, I have a question. Can you hear me? It's Anthony.
Sure. Yeah.
Great presentation, my friend.
Thank you.
You had a couple of slides back that you talked about, you know, not stretching your way out of this problem. And then you talked about this idea of the hip and the rotator cuff of the hip, similar to baseball. My question to you is, and maybe this isn't what are your go-to exercises that or buckets that you fill that you don't feel are maybe being used currently in physical therapy or in strength and conditioning that can work the quote unquote rotator cuff of the hip and then reposition the pelvis. I've always taken the approach in strength and conditioning it's a position problem. And if we can realign the position, now how long we can get that to stick for, I don't know. But we'll do a lot of things. For example, the gentleman was asking about goaltenders, and we have a goaltender right now that's, a lot of hamstring, a lot of posterior pelvic tilt, a lot of trying to open up, avoiding deep end range, squatting, et cetera, because he gets plenty of that on the ice. So again, sorry for the long-winded question, but what are your go-tos, if any, that you aren't being addressed right now in strength and conditioning and rehab?
Let me see here. I would say like something like this. So these are kind of my go-to. They're simple. They kind of, I know a lot of people are kind of getting away from isolated exercises. I still use them. I think, especially in a case like this where the hip cuff is not, it's hard to isolate for sure. So I think as much as we can and just getting it stronger. So, I like getting into the side plank because we're working both hips, right? We're working stability on the bottom hip while we're working any kind of like strengthening on the top hip, using, bands, ankle weights, that kind of stuff to kind of increase the load. I don't know if in terms of like physical therapy, if we do a good job of loading and progressing, right? So we tend to give, the classic 3 sets of 10, no weight, 2-3 weeks. And that's kind of it. Where the players that I've used this with, it's been more of like, we do different phases. We'll do like 3-4 weeks of an exercise continually progressing. And then we just kind of keep adding weight, adding challenge to it, over 3-4 phases. I haven't done it enough to say that it's worked super well, but the players that I've used it with I've had good feedback on it, and it seems to be working well. So, I'm kind of just running with this for now, until, something comes up where it's not working anymore. And then I'm going to start trying to figure something else out.
Any other questions, ladies, gentlemen?
Yeah, I have a quick one. So kind of building off of what you've been saying with this protocol, like I'm just kind of asking a big picture question for where you picture this going for physical therapy. Like FIFA has their protocol for ACLs. So do you picture eventually coming up with something or having the Kelly protocol and we use this as a prehab, something like that, where we're going through and you want to implement this with young players, the guys like Anthony who are doing strength and conditioning or physios, and picture it like a prehab where we start this younger and then build the strength so we avoid these injuries beforehand? Or is this a rehab protocol? Which of those two opinions do you think that you see more value in?
I don't know if I would expect it to be as big as a FIFA 11, but in the way that I would use it would be kind of a bit of both, right? Like I said, there's a lot of players have these hip changes without having symptoms. And when I say symptoms, it's more like pain, right? They're not seeking out treatment for stuff like this. But I think that if we can implement some of this stuff early on, we can kind of mitigate some of the effects of that micro instability, which can eventually lead to larger labrum tears, labrum irritation, that kind of stuff. So, I would definitely use it in younger athletes, people who are just looking to have healthier hips, as well as in a rehab population.
Awesome. Thank you so much.
Yeah, thanks.
Any more questions? Okay, Matthew, great job. Thanks for sharing your knowledge.
Thanks, Anthony.
Okay, I guess I'm last here, so please let me know if you're able to see my screen before I start going here. And let's see one thing here. Can everybody see this?
Yep.
Okay, let's see if I can do something real quick. Do you guys just see my screen or do you see it in presenter view? You there?
We see presenter view.
Presenter view, man.
Okay, let me get out of this. Sorry, rookie move here. Let me get it back to. We good here?
Perfect.
Awesome. Okay. So wanted to speak today briefly on injury in men's elite ice hockey. The goal here is really to explore injury rates, injury definition, and athlete exposure in men's elite ice hockey. And I'll define a little bit as we proceed on what men's elite ice hockey is. I wanted to thank my supervisor, Dr. Jim Dickey, same as Dylan's, and also I wanted to thank Dave Humphreys, who's a physical therapist in the School of Kinesiology at Western as well, who have been a great deal of help here on my journey, my PhD journey. So what we want to talk about, a little bit about the background of injury rates, athlete exposure, the methods that we used. We investigated this through an integrative literature review, the results that we found and the conclusions, and then open it up for any questions. So background. Well, currently both injury and athlete exposure definitions are inconsistent in the sport of ice hockey. So these inconsistencies really can impair the ability to compare cross-sectional data and assess trends across various leagues. We found that, everywhere from whether it's Tier 2 Junior A, Major Junior A, the collegiate ranks, National Hockey League or European professional leagues had different definitions of both, which led to a lot of inconsistencies and difficulties in trying to interpret injury literature in the sport of ice hockey. Obviously, ice hockey is a high-intensity sport where players can reach speeds of up to 48 kilometers an hour. These speeds and the nature of collision sports lead to musculoskeletal injuries at all levels of ice hockey. Obviously, hockey's played on ice, very minimal coefficient of friction. Players like literally high-end impacts are like small car wrecks. So we found through our review as well that plenty of musculoskeletal injury rates, a lot, believe it or not, in the lower extremities, specifically the knees. The gap. This paper or this presentation hopes to fill the gap by highlighting injury definition and athlete exposure inconsistencies, providing an evidence-based solution to investigate lower extremity injuries in ice hockey. We really wanted to focus as well on the lower extremity to really explore literally from the belly button down some of these injuries. So what we did is we conducted an integrative literature review on injury rates, injury definition, and athlete exposure in men's elite ice hockey. So men's elite ice hockey was really, we focused on players ages 16 years and older, playing either Tier 2 Junior A, Major Junior, college hockey, a European professional hockey, or North American professional hockey. Why that age group? We looked at the injury rates in youth ice hockey, and for the most part, the lion's share of those injuries occur after the introduction of body checking, which again is different in the US and Canada, but essentially U13 age group. So we decided to focus our research on 16 years of age and older. We use PubMed and Sport Discus as our search strategies and our search databases, rather. We had a total of 2,463 articles. After duplicates, we had about 2,200. We screened them. Basically, we ended up really investigating 28 total articles. And our inclusion criteria was, it was peer-reviewed. date that we searched was November 1976 through April 2019. Designed random controlled studies, cohort studies, case control studies, and cross-sectional studies. Again, gender were men greater than 16 years of age. Playing level, competitive, sport, ice hockey, and then types of injury were in our inclusion, which included obviously musculoskeletal, sprains, strains, and breaks. And our outcome was injury definition, injury rates, athlete exposure, mechanisms, and anatomical location of injury. What we found, injury rates varied from 13.8 per 1,000 player games to 121 per 1,000 player games hours. And obviously there's a lot of variability in those numbers. And that was literally based on two things. Number one, what was defined as an injury? So what was included as an injury? And then how they defined athlete exposure. You notice here it says player games and player game hours. Those are two different athlete exposures. And the problem is that different researchers used different athlete exposures, making it very, very difficult to compare data amongst leagues. So injury definition varied across leagues of all play, youth, junior, collegiate, international, and professional, making it difficult to evaluate. So we talk about athlete exposure up at the top. This was really confusing as someone doing due diligence investigating. You had really three athlete exposure definitions. And before I get too far ahead, athlete exposure, literally, it defines one event. It could be a practice or a game where there's an opportunity for injury to occur. That's an athlete exposure. But the way they were defined were very different. For example, player games was defined as total number of injuries divided by total number of players divided by number of games multiplied by 1,000. And from that, you'd get a number. Well, the issue being is that certain researchers would use one roster and other researchers would use both rosters, making those numbers difficult to interpret. To make matters even more complicated, you would get player game hours, which essentially is the opportunity during of injury over 1,000 games based on a 60-minute hockey game. This definition, not to confuse everybody, was the total number of injuries divided by total numbers of players on the ice. So that would be 6, right? You get 3 forwards, 2 defensemen, and a goaltender divided by the total number of injuries multiplied by 1,000, and you'd get a number of injuries per 1,000 athlete exposures. The difficulty there, again, defined certain researchers would use both teams on the ice, so they'd use the number 12. Others would use 1, so a number of 6 to define that injury rate. Again, making it extremely difficult to interpret the data. And the last one that we'd explored was total time on ice. And this really occurred in the National Hockey League, where they have access to literally the technology to do this, but essentially it was total number of injuries divided by the total amount of the player spent on the ice. So those were the athlete exposure difficulties in interpreting the data. But we came up with a conclusion that much like soccer and rugby and track and field, governing bodies in hockey should form a consensus definition regarding injury. Now, having said that, we, during our integrative literature review, came up with the International Ice Hockey's definition of injury as being the most, in terms of deepest description and easy to use. And it states that any injury sustained in a practice or game that prevented the player from returning to the same practice or game, any injury sustained in a practice or game that caused the player to miss a subsequent practice or game, a laceration which required medical attention, all dental injuries, all concussions, and all fractures. We feel that this is the most detailed description in terms and measures of what an injury actually is. Again, some definitions had no dental injuries, some had no concussions, some had no fractures. When looking at injuries, when I say ease of use, I want to be very specific. Really, injuries in hockey or any sport fall within 3 categories. There's a games missed injury, which is an injury defined as either you missed a practice or a game because of it. That's typically the easiest to use and the easiest to track. That is the International Ice Hockey's definition. So this would be considered a games missed category. There's also a category called medical, which essentially anytime someone gets injured, where they miss a game or not, if a medical staff looked at them, that's considered an injury. So it's jotted down as an injury. And last but not least would be all complaints. So if an athlete complains of something, hey, I think I pulled something, regardless if he or she missed time or not, that's considered an injury. If you look at team sports and the research that we investigated, the simplest to use and track is games missed. So this International Ice Hockey Federation definition of injury, we thought was a combination of easy to use and provided the best depth in terms and measures of what consists an injury. Athlete exposure definitions, when comparing time on ice metric to the estimated player game hour metric, the differences were very minimal. So what we did is we looked at the NHL information and their total, their aggregate for total time on ice and their injury rates. And then we looked at the same calculation using the player game hour metric. And we found very, very minimal differences. One was, 14,676 hours, and the other one was just a bit more in terms of 14,760. So we came up with the conclusion that to simplify things, most leagues don't have access to calculating players' time on ice. The easiest athlete exposure metric would be player game hours, which is, again, total number of injuries divided by the total amount of players on the ice, which is 6, divided by the number of games multiplied by 1,000 to get a consistent athlete exposure metric. So in follow-up, this was actually a quite challenging research expedition that we went on because of all the inconsistencies. But we feel if we could button up what an injury encompasses in ice hockey at elite levels, we're able to compare research across various leagues, across various demographics, even age groups, even at the youth levels. And last but not least, if we can do the same with athlete exposure, we'll be able to get a much clearer number of where we stand in terms of total injuries per 1,000 exposures. Any questions? I felt like that was a big monologue. Thanks for listening.
I have a question, Anthony. I don't know. I don't actually know how to say this, but like, what about like overuse injuries? Like, how would you define maybe like an overuse injury that doesn't necessarily, they don't get taken out of the game until like later on, like say like it goes on for a week or two and then it continues to progress and until they reach a point where they start missing games. Like would that be, I guess that's kind of.
It's interesting. I can answer that question just by telling you what we looked at in the research. Obviously, the definitions that are being proposed as of more recently, like by the IIHF, you're getting a little bit more of what encompasses an injury, but you're going to see a whole breadth and depth. Like I said, some had no fractures, no lacerations. Some did. Some did not have concussions. Some did. I don't think that that's a bad way to do it. The way we're trying to view at least our proposal was what's the most practical and easiest so we can compare data across.
Mm-hmm.
That would fall into more an all complaints.
Okay.
And not a time loss. When looking again at the literature in other sports, other team sports, be specific, like soccer and rugby, you're going to deal with much more time loss because from an aggregate, it's easier to track. So do I think those injuries are important? Absolutely. But in terms of encompassing an athlete exposure and an injury definition, from our experience, I'd probably steer more towards that time loss just for the simplicity.
Sure. Yeah, that makes sense. Thanks.
Of course. Any other questions? Okay. Hey, thanks everybody for your time.